Hi, this is ClarenceMonteclaro. We'll be discussing today the health inequities in Los Angeles County as it relates to the operations of the Department of Public Health, whose mission it is to protect health, prevent disease, and promote health and well-being for everyone. The key priorities under consideration is how this Department of Public Health advances health equity and reduces health disparities through the operations of 14 public health clinics to provide free or low-cost services to over 10 million residents in Los Angeles County. The key stakeholder of interest is the clinic service medical director. The Department of Public Health's organizational goal of consideration is that by January 1st, 2023, the clinic service medical director will expand the sexual health clinic schedule by 150% to 12 visits per session. The accountability relationships we're looking at is that of the medical director being accountable to the director of the Department of Public Health for the planning, implementation, and driving of the clinic schedule expansion. The objective here is to increase access to public health services and provide timely communicable disease treatment. The return of expectation is to improve health outcomes and reduce health disparities. To evaluate this project, we use the Kirkpatrick Implementation and Evaluation Framework, which involves 4 levels of evaluation and implementation. Level 4 considers results, an assessment of targeted outcomes for the provision of training and supports. Level 3 looks at behaviors, the critical behaviors, assessing the participants' incorporation of acquired learning after returning to work. Level 2 looks at the learning done, an assessment of the participants' acquisition of targeted knowledge, skill, attitude, self-efficacy, and motivation. And level 1, the reaction of the participant, an assessment of their views of the training as meaningful, engaging, and applicable to work needs. So we begin this evaluation with level 4, a consideration of the results, the external outcomes and internal outcomes, by which the outcome is identified, measured, and collected. We begin with the external outcomes. Number 1, an increase in the average number of patients seen per session. Number 2, a decrease in the interval time to initiate HIV treatment after new positive HIV tests. And number 3, to increase the number of new syphilis cases treated. These are assessed over the past 3 months and solicited quarterly. As for internal outcomes, we look at the increase of staff's confidence to manage an expanded schedule, and a decrease in the average wait time for each clinic visit. These are collected in a semi-annual survey or through quarterly accounts of the clinic visit wait times. Next, we assess level 3, the critical behaviors, and on the next slide, their drivers. For critical behaviors, we look at 2, the direct semi-annual clinic workflow training to improve staff confidence. This is a metric that looks at the number of providers scoring with moderate to high individual confidence to manage an expanded schedule. This is assessed through a survey of all involved staff on their individual confidence to manage that schedule. And the medical provider will be the individual to make that assessment. They will also be responsible for workflow management and targeted training for all involved staff. This will be done on a semi-annual basis. The medical director will review quarterly workflow management practices, gaps, and interventions that are implemented. Second behavior, to adopt on-the-job support and interventions to reduce clinic visit wait times. This is done through the assessment of weekly average number of major interventions needed to address prolonged wait times. The medical director will designate a nurse lead to help monitor prolonged wait times during each session and reallocate needed resources. The monitoring of weekly average clinic visits We'll also present trends over time and whether those trends rise above an upper control limit will determine whether targeted intervention is implemented or not. This will be done in general on a weekly as well as quarterly basis. Looking at the required drivers for these critical behaviors, we consider reinforcing drivers, encouraging drivers, rewarding drivers, and monitoring drivers. Reinforcing drivers occur on an ongoing weekly and semi-annual basis, driving both critical behaviors in regards to leadership meeting with staff to identify training goals and standardized practices, holding team meetings to improve staff confidence and self-efficacy, setting up a project charter to clarify goals, scope, work practice, and roles and responsibilities, workflow modeling that removes inefficiencies and optimizes clinic wait times, and creating job aids on the reallocation of resources to mitigate clinic wait times outside of control limits or upper control limits. Encouraging drivers includes leadership mentoring with executive director support on an ongoing basis, and leadership coaching with change management experts on a weekly basis. Rewarding drivers includes the executive director's acknowledgement of organizational goals met by the medical director, as well as staff appreciation of the medical director as a trusted leader. Monitoring will occur on a semi-annual, quarterly basis through a pre- and post-training staff confidence assessment and quarterly review of workflow management practices, gaps, and interventions implemented, as well as of project performance relative to improve clinic wait times. The next stage would be looking at areas of learning for the medical director, and we consider declarative knowledge, procedural skills, attitude, confidence, and commitments. Under declarative knowledge, we look at the medical director's knowledge in regards to project charter elements, their knowledge relative to the number of providers scoring with moderate to high individual confidence to manage an expanded schedule, so being familiar with the status of that, as well as of weekly average number of major interventions needed to address prolonged wait times. This is done at various intervals. Under procedural skills, we look at learning relative to demonstrated creation of a project charter for semi-annual clinic workflow training, action plans relative to assemblage of a leadership team to set staff training goals and standardize clinic workflow, an action plan to look at the design of semi-annual team meetings to improve staff confidence and self-efficacy. Under attitudes, we consider discussions with the executive leaders, as well as change management experts, and a weekly self-reflective journal maintained by the medical director. For confidence, we consider a pre- and post-program survey and a mentorship check-in with the executive leaders. We also do a coaching check-in with the change management experts to assess confidence of the medical director on whether they can do the job or not. Lastly, commitment on whether the job will be done. We observe on-the-job integration of workflow modeling interventions to reduce clinic visit wait times. And this is done both during and after the intervention. Under reactions to the program, we look at the methods or tools of assessment, and this would be for engagement, assessment of relevance, and assessment of customer satisfaction. For engagement, we monitor how the medical director attends change management coaching sessions on a weekly basis, or attends executive leader mentorship sessions on a quarterly basis, and whether they complete their weekly self-reflection journal. As for relevance, we assess with a pulse check with the executive leader discussion on a quarterly basis and conduct a survey with the medical director on a semi-annual basis. As for customer satisfaction with the program, we do a weekly observation with the change management coach and a semi-annual survey with the medical director. Lastly, we'll break into a brief discussion regarding a few questions about equity relative to ontological and epistemological accountability. Here we consider why is it important for the medical director to espouse the organizational value of health equity to realize targeted outcomes, as well as how is it possible to realize targeted outcomes but miss on reducing health disparities. Next, we consider what potential complications could arise in having the director involved as a key driver for the medical director's critical behaviors. And lastly, how should the medical director be held accountable in the absence of targeted health equity outcomes, despite adequate learning and performance of critical behaviors?